Okay, so now we are looking at nephrotic syndrome. It is glomerular syndrome characterized by massive proteinuria, hypoalbuminemia, generalized edema, and hyperlipidemia, means increased lipid and proteinuria, release excretion of urine from excretion of protein in urine, and that's why edema is present in this nephrotic syndrome. Now, causes of nephrotic syndrome are minimal chain disease, membranous glomerulopathy, membranoproliferative focal segmental glomerular sclerosis. Systemic diseases includes diabetes mellitus, SLE, amyloidosis, and cryoglobulinemia. Now, what workups are in labs will be required for this is base initial test is urine lysis, then urine biopsy, then urine lysis is not sufficient, then proteinuria is estimated for 24-hour urine protein collections. Treatment for nephrotic syndrome is protein supplementation, diuretics for edema, treat hyperlipidemia with statin and sodium restrictions should be given. In this way, we can treat nephrotic syndrome. Specific measures like ACE inhibitors, ARBs should be given, and for primary glomerular diseases, steroids should be given. For secondary diseases, underlying cause should be treated, and for infections, antibiotics should be given. So, in this way, we can treat nephrotic syndrome. Now, coming to the first disease of the nephrotic syndrome is minimal chain disease, also known as lipid nephrosis. Most common cause of the nephrotic syndrome in the children, cytokine mediated damage of the glomerular basement membrane, and it presents with the respiratory infection, immunization, atopic disorders, Hodgkin, and SARS. Different types of nephrotic syndrome are highly selective proteinuria, no hypertension, no progression to renal failure, excellent response to corticosteroids is there in nephrotic syndrome. Light microscopy shows no change. Fluorescent microscopy shows no change. Electron microscopy shows visceral epithelial cells with diffuse effacement of the food process. In this way, nephrotic syndrome presents. Membranous glomerulopathy is another disease. It is most common cause of the nephrotic syndrome. Causes are idiopathic. Drugs like captopril, gold, penicillin, and autoimmune SLE, thyroiditis, hepatitis B, C, syphilis, malaria, lung cancer, colon cancer, and melanoma can create this condition. Now, clinical features are non-selective proteinuria, hypertension, progression to renal failure, and good response to the steroid therapy. Renal biopsy shows microscopy, subepithelial deposits of DBM, spike and dome appearance, and focal segmental glomerulosclerosis is characterized by sclerosing of the glomeruli and capillary tuft. Causes are idiopathic, HIV nephropathy, heroin addiction, sickle cell disease, and massive obesity. These are the focal segmental glomerulosclerosis. Clinical features will be in young patients, it is because of uncontrolled hypertension, microscopic hematuria is there, and renal biopsy shows sclerosis of the capillary tuft. So in this way, nephrotic syndrome presents. Another disease is membranoproliferative disorder, glomerulonephritis. It results from activation of both classical and alternative pathway of complement system, are associated with hepatitis B, C, cryoglobulinemia, and SLE, and bacterial endocarditis. And in type 2 disease, dense deposit disease is there, and C3 nephrotic factors are there, C3 convertase is there, C3 level is also there. Renal biopsy shows subendothelial deposits, intramembranous deposits. Renal amyloidosis shows accumulation of insoluble fibrillar proteins. So in this way, nephrotic syndrome and different types of nephrotic syndrome presents. Now looking at urinary tract infections, UTI, lower UTI is urethritis and upper UTI is pyelonephritis, inflammation of renal parenchyma, while urethritis are cystitis, inflammation of the urethra and bladder. And clinical definitions are there, infection, and then different, more commonly occurs in women, but it also presents in the men as well. Laboratory definitions will be bacteria will be there, UTI will be there, presence of pus cells will be there. E. coli shows UTI and causes overall UTI. E. coli, Klebsiella, Proteus, Pseudomonas, Yersinia, yeast, and Chlamydia trachomatis also there. Clinical features are urethritis, cystitis. Urethritis is urethral discharge with no fever, dysuria, urgency, frequency, and hematuria. Cystitis is dysuria, frequency, hematuria, and pain. Pyelonephritis has classical triad of fever, chills, and loin pain, tenderness, nausea, vomiting, and diarrhea. And pyelonephritis means upper UTI. Renal abscess in the manner of identical pyelonephritis. And then prostatitis has chronic prostatitis, no fever will be there, dysuria, urgency, frequency will be there, symptoms will be obstruction, hesitancy, of dribbling of the urine will be there in prostatitis. Acute prostatitis presents with the fever and perineal pain, tenderness, digital rectal examination shows enlarged prostate. are inflamed. So investigations will be urine dipstick, urine lysis test. For pyuria, WBC will be increased leukocyte esterase, increased nitrates, and with or without hematuria. Urine culture is gold standard investigation, and UTI presence of the pure growth asymptomatic bacteria will be there in pregnant women, infants, and those in the urinary tract abnormalities. Sterile pyuria will be there, and then calculi, prostatitis, bladder tumor, and polycystic kidney disease will be there. Other investigations: CBC, ultrasound, electrolytes, blood culture, DNA detection, chlamydia, trichomonas, Neisseria, gonorrhea, bacterial renal tract, CT children will be the recurrent UTI, renal ultrasound, IV urogram, CT scan, voiding cystography will be there. Treatment will be fluid intake, urine alkalization should be there for potassium citrate and cranberry juice. Amoxicillin, nitrofurantoin, and cefalexin ciprofloxacin should be there. Urethritis as Neisseria, chlamydia with there. And in pregnancy, any bacteria, asymptomatic pregnancy will be there. Drug of choice are cefalexin, amoxicillin, nitrofurantoins will be there.